Greetings, everyone. My name is Dr. Kiosha Partlow. I'm Director of Urban Health Institute at Charles R. Drew University of Medicine and Science. It is my pleasure to welcome you to our Dr. M. Alfred Haynes lecture for the month of April. Really quickly about Dr. M. Alfred Haynes, he's a former dean and president emeritus of CDU, and also a major architect of social justice and pioneer in addressing health disparities in health status, access to care, and also professional health education opportunities for the most vulnerable. It is truly an honor to have Dr. Paul Robinson as a speaker for this month, and it's indeed very timely. Dr. Paul Robinson is an assistant professor and director of the Medical GIS Laboratory at CDU. He also has extensive expertise in geographic information science and a track record of working with researchers seeking to understand how local, social, and environmental processes impact health, adherence, and also outcomes and treatment. He has introduced concepts and theories from geography that have aided in devising sophisticated conceptual models and also research methods and understanding and addressing chronic diseases, healthcare utilization patterns, and other issues. And some of his current work focuses on vulnerable populations impacted and affected by COVID-19. Without further ado, again, we want to go ahead and turn it over to Dr. Robinson. Thank you and welcome.
Okay, thank you, Dr. Partlow. Can everybody hear me? Can you hear me?
Yes.
Okay.
Yes, we can hear you.
Okay, thanks. So today I'm going to be sharing some data that and some preliminary, I can't say analysis, but preliminary data that I've been putting together for actually an NIH supplement, administrative supplement to that. There's an RFA, and they're looking for people to help understand two areas that I can help with. One is the natural evolution of COVID-19, and then more specifically, how geographic differences influence racial and ethnic outcomes for COVID-19. So this is all preliminary work. There's not actually, as you'll see here, the data is very spotty, and it must be interpreted with care. So to get started, first, let's just talk about what is coronavirus. So, and some of this stuff, most of you already know, some of you may not know. I will cover this in order to set up the discussion about the disparities and the social factors and how those are being exacerbated. So coronavirus, as you know, probably know, it's a type of virus. It's believed to have originated in bats. So it's different from, say, H1N1, which was a bird origin. And pretty much it's accepted to have first crossed over into humans sometime in late 2019. And as you may or may not know, that these viruses that are in wildlife sometimes hop over to humans, and the process is called zoonotic transfer. So I won't go into that, but that's the process through which viruses and ailments that exist in the animal world cross over into humans. So they don't really know how this happened. So there's a focus on a wet market in Wuhan, China. There's also some belief that possibly because there is a biological research lab in Wuhan, that it was escaped from a lab. But now, whether it was created in a lab is very unlikely, but it could have been something that was being studied in a lab and escaped from a lab. So again, these things occur in nature. So now this virus, and I'll talk a minute about what a virus is. This virus causes a condition called COVID-19.
Yeah, sorry, there is a
Hello?
lecture.
Hello? Question? Is that a question? Okay. So this virus, coronavirus, which again escaped from the animal kingdom, causes a disease known as COVID-19. And COVID-19 is the disease. And since it came out of China, it's spread around the world. And as you know, it's brought the global economy to a grinding halt. The effects of COVID-19 have been unprecedented. Never has this happened in the whole world, probably, in the history of the entire world, where almost all governments are fighting it or preparing for the onslaught of it. Orders, shelter in place, stay at home, safer at home, and of course, keeping your physical distance from others is a public health requirement for fighting COVID-19. So, what is a virus? Actually, viruses are important parts of the global ecosystem, and viruses exist in bacteria, they exist in plants, they exist in animals. And viruses are important in the evolution of living species. So, we're looking at them as a disease and something bad because they do cause diseases, but they are there in nature. There's debate, there's a vibrant debate over whether a virus is alive or not, right? But whether it's alive or not, it doesn't really matter to me. It is organic, and it is a part of the ecosystem, and there are many, many viruses. So, and they actually attack cells, and they transfer RNA and DNA, and usually the virus's process results in damaging or killing the host cell. So they're a parasitic organism that can only that can only function in living cells. And they're actually, sometimes they seem intelligent because they mutate, and they develop mechanisms to attack cells and to reproduce. And so again, I won't get into whether they're alive or not, but is the earth alive? That's a question that's now being questioned. So is everything alive, right? So I'm not going to get into whether a virus is alive, but they're definitely organic. They're organic nanoparticles, right? Viruses are very, very small. So we talk about nanoparticles. A virus is a nanoparticle from God, for example. It's very small and it's organic. They have DNA or RNA. And I don't really even know the details of this, but the structure of the virus is such so that it attempts to connect to a cell and then inject the either RNA or DNA into the cell. And so here's the ubiquitous picture of what under an electron microscope or something, what a coronavirus would look like, what it looks like, right? So again, I'm not going to spend too much time on this other than to say that, there's good knowledge of the structure of these coronaviruses. The common cold is a coronavirus. SARS was a coronavirus. So when you look at the structure of it, you can see there that the RNA is inside, and it's an RNA virus, and there's those things on the outside help it attach to whatever the host cell that it's trying to target. Okay, so that's kind of the mechanics of the coronavirus. And then what happens is that if it can get into your lungs and attach to the, I believe it looks for the ACE receptors, and it then causes, it produces a tar-like substance which builds up, and your normal lungs have something called a cilia on them, and your lungs will expel. So, you're either going to cough it out or you're going to swallow it. If you have some foreign substance in your lung, there's cilia, which occur kind of these moving little nodules that move stuff out of your lungs, and that's the normal lung. But if you get the COVID-19, the virus functions in a way that allows for fluids and debris to build up, and that's where the complication that's killing people and causing people on a respirator occurs, and that's pneumonia. So you can't breathe; you're actually drowning on land because inside your lungs there's this buildup of debris, and so that's the scary effect of COVID-19 that everyone's trying to avoid. Some people just get as you know, some people are asymptomatic. They never even know they had it. They just maybe have a little bit of a cough, or they lose their taste and their smell. Other people get the cough and the fever. Most people get some kind of fever, and then the severe complications lead to respiratory failure. That's why it's a SARS, severe acute respiratory syndrome virus. It can cause severe acute respiratory failure, and that's when people need to go on ventilators, right? So that's what it does to people. And so I don't know how they got Tiger Woods to pose for this picture of COVID-19, but it sure looks like him to me. But anyway, so you can see that these are the symptoms that can occur, and then a complication of that buildup of mucus would be pneumonia. Okay, so any questions about the virus and the disease that it causes and how it attacks cells and what it does to people? Okay, no questions. Hello?
Yeah,
Somebody had a question?
there's some questions in the chat if you want to take a look.
Okay, can someone read those
Yeah,
to me? It's very hard to do that.
I can read them. The first question is, there's an article shared by many on social media that China created the virus to compete with the US. Is this even a thing, and is there any truth to this?
Okay, I have thought that. I have not. I mean, I don't know. I don't have the answer to that. I don't believe that they did not. So the answer to did China created the virus is definitely no. Is a resounding. You can't create a virus. They may have observed the virus, taken it out of the bats, and started studying it in the lab. So that could be true. But I mean, creating a virus, I don't know. Maybe I'm wrong, but I think viruses occur in nature, and people observe them, and then they can like replicate them, and they capture it and store it. So I don't know the answer to that, and actually, right now, it's not that important whether it was somebody, killing bats and butchering them next to food, or whether it came from someone who went from that lab to the market in Wuhan and passed it off. It doesn't really matter. But I don't know. That's a geopolitical, and I'm the kind of person that does think about that. I am a geographer, a human geographer, but I defer that to a different conversation later on. Whether and then. If they did it, it backfired on them because all of the global orders that China used to fulfill are no longer happening, right? So China's hurt by it too, even though they're maybe past it. Their economy is in shambles because their economy depends on the rest of the world. So I don't know. That would have been a good idea because it doesn't give them an advantageous position. But again, I don't know. So so that's my answer to that question. Any other questions on the virus itself?
No, there are no other questions. And others, if you have questions, feel free to add them to the chat box, and we will read them.
Okay, so now let's move on to how this virus has spread and what the social implications and the geographical epidemiology of the virus. So this is a projection that breaks out the daily deaths for coronavirus, and it's fairly recent. And so basically it has countries, and then it has regions, states of the US broken out along with countries. So this red line here is China, right? And so China was one of the first countries, and you can see my cursor, right? That I'm moving here. So
yes, I can see it.
You can see that by February, China had over 100 cases, and daily deaths. It had, over 100, almost 200 daily deaths per day. But by the beginning of March, China, because of their ability to institute very draconian social distancing. So I have a Chinese colleague, and I was talking to him through Facebook throughout the entire epidemic, and he basically, it's kind of scary when I think about it, because he basically described what exactly was going to happen in the U.S. before it happened in Italy. And he even said, I'm pretty sure the rest of the world will not be able to take the kinds of measures that China took to stop coronavirus. They welded people in their houses. They locked people in their houses. They went door to door. They checked the people for the disease. If you tested positive, they took you right then to a hospital. If you're a single mother, your kid went into foster care or something, you went to the hospital. There was no, we're not New York, we're not China. No, they were Wuhan, and the thing was really basically contained within Wuhan through the kinds of social measures that a large centrally organized state like China was able to institute. Okay, so that's the story that we have, at least. So, and that, I have no reason to doubt that the numbers may be inflated or underinflated, but compared to the rest of the world, China was able to contain this. Now, this line here is Italy. So basically what happened is that there's as you probably know, there's a historical connection between China and Italy. It goes back to Marco Polo. And particularly in the north of Italy, it's the industrial homeland of Italy, and there's a lot of clothing production. And they source a lot of their products out of China for the Italian fashion industry and clothing production, shoes and things like that. Italian shoes are made in the north of Italy. So there was connections between China and Italy. And when the lockdowns went in place in China, a lot of people went to Italy directly from China, bringing coronavirus with them. And so why is Italy the epicenter? Well, pretty much because they had some business, their business connections with China. So from Italy, with the European Union, you could see if you look at I'll talk in a table that I'll show you in a minute, it's spread to most of Italy. I mean, most of Europe. So if you combine Europe, all the countries of Europe, you have more deaths in the U.S. to this day because, you're looking at a whole region, an economic region that has interrelations and trade. So coronavirus moves with people. Why do they have to shelter in place? Because people moving causes coronavirus to move, right? So now, basically, I just want to show you this to show you like the temporal evolution. And so you can see New York as a separate line right here, right? Here's the U.S., here's Italy, here, Spain here, right? California's on here as well, right? So, so California, we're actually down here. We've never really reached 500 or 1,000 deaths per day. So you can see, and this is actually this model under forecast because, this model was about mid-April predicting a peak of about 1,900 deaths per day in the U.S. Well, if you look at the U.S. yesterday, there were 2,400 deaths. So it's already gone over that. And but that's the kind of curve. So when they talk about the curve, flattening the curve, places like California and Washington and Oregon were able to flatten their curve, but the U.S. in general was not able to really flatten the curve because you can see these numbers. So this is yesterday's cases, right? So yesterday on April 15th, the U.S. had about 30,000 new cases and 2,500 new deaths, right? As opposed to Spain, Italy, which only had 2,700 new cases and about 600 deaths. And you can see the UK is having a very severe problem with coronavirus. They had 761 deaths yesterday. They gained about 5,000 cases. Other countries that are having a problem, China is not having a problem as much. They had 1 death yesterday, 46 new cases. And they're claiming that the cases that they're experiencing are all coming from outsiders. In fact, there was a big diplomatic row between China and a bunch of African states because they were abusing Africans in Guangzhou, north of Hong Kong, because they thought that 5 Nigerians tested positive to coronavirus, and all of a sudden, every African in that province was being put out on the streets. And you can just look you can look these things up on the news. Things I talk about, check it out. It's all there. So Iran has a big problem. They're still having a problem. 94 deaths yesterday. Turkey, nobody talks about Turkey, but Turkey is having a huge problem. I won't go too far into this. You can look at this data yourself. It's all over the internet. But what I do want to point out is that with the exception of China and the US and Iran and Turkey, most of the cases are in Europe, but there's rising countries like Brazil, Russia, India, which they'll be the second wave of coronavirus. So China, US, and Europe were the first wave. But it's rising up now as these countries go over the crest and it starts to die out. You start to see that in these other countries, Israel, India, Russia, South Africa, go further down here. Mexico is rising very rapidly here. And again, that's a whole nother talk, but you could get into that. You could look at the natural epidemiology. So forgetting the national situation, international, we can go to the US. And as everyone knows, New York is the epicenter with over 200,000 cases, 752 people died in New York yesterday. Other states that they talk about are here, Massachusetts. And so again, these are just the raw numbers. But I do want to bring your attention to the right side over here. There's data on tests and tests per million population. And this is a key thing in the COVID-19 puzzle because this data is not good data, right? First off, don't misinterpret this data. This is data that only tells you how people are interacting with the healthcare system. This is not data that tells you how far it's penetrated into the population. This is not data that tells, now the mortality data, hello? Hello? So the mortality data will tell you a little bit about ultimate consequences of coronavirus, but as you know, and as you'll see, these are exacerbated by interactions with the healthcare system. So
Dr. Robinson, there are a couple of new questions that have come up.
Okay, I'm getting to the end of this section, so let me just finish this section, then I'll take those questions.
Great, okay.
So this data that I'm showing you, it's authoritative data on confirmed cases. It's authoritative data on tests, maybe not so authoritative on the tests, right? But it doesn't mean much other than this is the interaction of people that have coronavirus with their healthcare system. They're either getting confirmed, tested, they're dying, or tested, getting confirmed as sick, and dying. That's all we know about it right now. And that's why this antibody test and all these tests are very important for anyone being able to address this problem anywhere in the world. And as you can see, there's great discrepancies between tests per million person at both the international level, here, and as you go down here, if you were to go to countries in Africa, for example, there are hardly any tests. They don't even, there's cases, but they're identifying new cases, but their testing is, and that was a problem in California for a while. So you can see here, while New York has tested 27,000 people per million, California has only tested 5,500 people per million population. So we really don't even know what the epidemiology of coronavirus is in California, actually. We do know that, and that's what's scary because, okay, I'm getting ahead of myself, but people should be on here that aren't on here in terms of death, in terms of diagnosis. And if you talk to any clinician who's treating coronavirus right now, they will confirm that. So now I can take the questions now.
Okay, the first question is a second wave due to the fact that most of these countries are in the southern hemisphere and their summer is starting?
Okay, that I am not an expert on that, but I have done some research. I know that the last time I checked, there were 4 different strains of coronavirus around the world. And as you know, if you know about viruses, they mutate to find the best conditions for their replication. So the coronavirus that's going to be in sub-Saharan Africa or the coronavirus that's currently in India is not the same coronavirus that's in Europe or North America. And it's the same virus, but there's subtle mutations that allow it. So the seasonal effect does not occur. Flus that are seasonal in North America or in Europe are not seasonal in the tropical regions. So again, there's other people on campus and all that are way more experts on this than I am, but I do know that the things I read and the research I did indicates that is not, you can't compare the coronavirus that we're experiencing with whatever is percolating in sub-Saharan Africa right now, because there's at least viruses can mutate. There could be 20 different strains of a virus, and that means it's extremely because each vaccine has to be targeted to that strain. So the last I heard, coronavirus is a fairly stable virus, but there are still at least 4 strains of it. So wave 2, it's a function of, yes, the virus mutating, people carrying it, traveling around, and so whatever happens in India is not going to be necessary. Just like in the US, it's killing way more young people than it did in China. So again, I haven't mapped out, I've seen a map of where the different strains are, but I didn't prepare that for this presentation, so I can't really address that right now. But I do, to answer your question, it does have something to do with geography because the virus mutates, but the virus is able to withstand heat. I mean, it mutates so that it can withstand more heat to survive in the tropics. And that's just how these viruses function. So any other questions on that?
And the second question was how much of new cases in the US reflects more testing as opposed to new acquisition of infection? Deaths are real numbers, but reflect in part people who acquired infection possibly weeks ago. Without more widespread screening, we may never know the real denominator.
That is a very good question. And honestly, a lot of the new cases definitely reflect new testing. You test more, but who are you testing? And there's a lot of people that had coronavirus, it's resolved, they never knew they had it. There's a lot of people who had coronavirus, they got very sick, and they never knew they had it. There's a lot of people who had coronavirus, and they died, and they never knew they had it. And they're not showing up in any statistics. They're not, and that when we get to talk about LA County, I'll get to more of that. But so these are disparities in life as Americans that are being exposed by coronavirus, right? The virus isn't doing anything but doing what a virus does. But this particular virus is very sophisticated. The fact that asymptomatic people can transmit it without ever knowing they had it. The fact that it waits 5 days, at least sometimes 5 days or more before people know they have it. It's like this virus has learned from all the mistakes, because say you take SARS, that virus was hardly contagious at all. If you didn't work in a hospital, you probably didn't get SARS. If you didn't care for somebody who had SARS directly, it wasn't this. And then H1N1 was a virus that didn't kill enough people, right? This virus kills just enough people and is very tricky in that it fools people. It's like it plays upon the hubris of human beings. Oh, we're not China. Yeah, you're worse than China. Oh, we're not New York. Yeah, you're worse than, yeah, we're not, boom, it's there. And it makes people wait. Oh, we don't have to social distance. So again, I don't want to praise COVID-19 too much, but it's a very sophisticated entity coming from the environment. Makes you wonder, is this a correction for human beings? Because Mother Nature is very happy right now. There are no pollution. The animals are loving it. So again, I don't want to get into that. That's a philosophical thing or whatever. But you might want, like, as I said in the earlier slides, from an evolutionary biology perspective, viruses are underrated. Their importance in forcing change is underrated. Well, this one forced some change on a whole lot of people. So anyway, now back to the health disparity. So we have this situation, and many of us at Drew have been studying health disparities for years and years, right? And we saw this coming. We didn't see COVID-19 coming, but we knew that these types of situations are going to expose what's happening. And so these health disparities are driven by things that are bigger than health. They're driven by things that are beyond health. They're driven by race and nationality and class and things like that, right? But with all disasters, both health, natural disasters, wars, whatever, the most socially vulnerable are the most affected, right? And this is being laid bare in the coronavirus thing, right? So let's talk now about coronavirus in the US. So as you know, it's from what the press comes and all, there are regions of the country that haven't hardly been affected by coronavirus. They can open up, let's get the economy started, blah, 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 right? Well, it's true that the mid-Atlantic region is the most affected. So we call that the Bosnia-Wash megalopolis. So the area between Boston and Washington is almost continually developed, right? There's only a few areas that are not developed. And that area has hit the hardest, and I'm going to show you some graphics on that in a minute. But it's though it has spread to the southeast, where there's a potential huge problem, and then cities in the Midwest like Michigan and Chicago, and then a few others places have also been affected, right? And so it's unique how coronavirus hits a place is very unique to the built environment of that place. So New York, Philadelphia, those are the old colonial regions, and things are really close together. People can't hardly walk down the street without passing them, and the high population density, and then a lot of people that like to go to bars and recreate in these places, these businesses. That is definitely a factor in it spreading in those areas, right? So Western regions, with the exception of the Seattle area and our Southern California area, have not been as affected, and I'm going to show you that in a minute. All right, so okay, so any questions now? Anything I just said about the U.S.?
No.
Okay, so now what people are noticing on the individual level, not on the neighborhood level, is that a lot of African Americans are dying from coronavirus, right? Not saying that no one's saying that the infection rate is higher amongst African Americans. We don't really know that, and very probably unlikely. It might be a little higher in some neighborhoods because of the way people live, but the death rate is extremely high. So these are studies from I think it was this Tuesday. 407 of them were African American. So the race. So Michigan, 298 versus 203, and then the rate, when you consider that in the population, the death rate for African Americans is 27 per 100,000 versus 5 for whites in Louisiana. It's 21.6 per 100,000 in Michigan versus 2.6 for whites in Michigan. It's 7.2 in Illinois versus 1.3 for whites, and in North Carolina, those rates are much lower, but still there's a discrepancy, right? So there's clearly, in these cities, an overbearing number of African Americans who are dying from coronavirus. Now, the data that we have on that is very limited. We have data on cases and we have data on deaths right now. We don't have good, and this is from like the perspective of researchers, like every little health department has this data, but they're not sharing it. There's a big problem that the reporting up of things like deaths by neighborhood or death rates by race, that hasn't yet happened. Like the LA Times had to get this, LA Times had to go call up these health departments. There's no national database which can give you the deaths by race, right? So, and these have been written about. So if we had good data, we'd know the total cases, we know the population rates, we know the deaths, we know the population rates of death, and we know the tests and the population rates of tests, right? But as you've probably seen in the news and all, we're not there yet, right? Okay, so, but what do we know with the current data set, the data that we have? This would be a time if there's any questions I can answer them while this is loading. Oh, never mind. So I put this little web app together to show the natural epidemiology of coronavirus at the national level. So basically, what you see here are confirmed cases by county in the US, right? And so you can clearly see that this Bosnia-Wash megalopolis is where there's almost a continuous collection of cases by county, counties with high cases, right? And so this is all from, so you can see this is DC, Prince George's County, this is New Jersey, Monmouth County, New Jersey, this is New York area, Nassau County, I still live in that county, that's a county on Long Island. So you can basically see that in New York, if you were to click on any of these, you could get ideas. So let's look at Nassau County. Nassau County has experienced 27,772 confirmed cases, 1,109 deaths as of today. And this is real-time data. This is actually coming from a data stream that's updated. This is the Johns Hopkins data feed, and I just took it and put it on here. So you can see that there's no data from the Johns Hopkins data feed yet. They have the fields for people tested, people hospitalized. That data is not available yet. And they're like one of the central repositories trying to provide this information for researchers. It's not available. All we have right now at the county level, we have is number of confirmed cases, number of deaths, and then the incident rate. So this is 2,047 people per 100,000 people have had coronavirus. So 2% of Nassau County has been confirmed of having coronavirus based on this figure, right? So this is just raw numbers, right, for cases. So again, this is a good visual. So again, when people say the data doesn't mean anything, that's not true. Just don't try to make it mean what it doesn't mean. What this data means is this is the caseloads that have been identified in the US for coronavirus. So if we come over to our side of the country, you can see that, and I look at this frequently, it's gotten changed because there was a time where LA County was the only big county and Riverside and San Bernardino were still small, didn't have a lot of cases. But in the last few weeks, the caseload of our suburban counties of Riverside and San Bernardino has grown as well. So as you know, here we are. We have 10,517 confirmed cases, 405 deaths, but our incidence rate is only 104 per 100,000, as opposed to you saw in Nassau County, it was 1,000 per 100,000. So we have 10 on the West Coast, and now I'll show you. So let's move to so again, and anyone you want to play with this, this is on the website, the GIS website, and there's other stuff. We put more stuff up frequently, trying to help people do research on coronavirus. Here's Denver area. So anyway, you can see that a lot of counties don't have, in the middle of America, don't have a lot of cases. So Wichita County, Kansas, or something here. This is Sedgwick, Kansas, 219 confirmed cases, 3 deaths, right? So when you hear the government talk about opening up 20 states or whatever, what are they talking about? So let's take this, and instead of looking at this, we're going to look at the rates instead of the raw population. All right, so I'm going to turn off the raw, and now we'll look at the rates. This is where you get disturbed about what's happening in the South. So this is the rate per 100,000 of coronavirus by county in the US. Totally different picture here, but what you definitely see is what they're talking about. West Coast places have lower population rates relative to both the Northeast and the Southeast, right? So these are rates, and so you can see now, you start to see that rural areas in the South are struggling with coronavirus because the rates, maybe they don't have a lot of cases, but they have high rates, right? So again, it does start, you can see the regional factors. So when they're talking about opening up the country, they're really talking about places that have low rates. So here in West Virginia, Southwestern Virginia, Texas, even Florida, relatively well. It's not as low. So you can see the rates in Florida are a lot lower than the rates in Georgia. So counties in Georgia are really high. All right. So now that's kind of the overview. Are there any questions? This is a county level analysis here. So you can really see the epidemiology of coronavirus clearly here in terms of what the confirmed cases, right? And the rate of confirmed cases. But again, in all these areas here, how many people are not even entering into the healthcare system? Or if they do, and I can tell you that a clinician that I know who's at the front lines, who is associated with Drew too, confided in me that because of the lack of testing, they have been telling people, they've saved the test for healthcare workers and people who are being admitted to the hospital. Everyone else, they presume you have COVID-19, write down pneumonia, and send you home and wait till you come back sick enough so that they can admit you, and then you get a test. So that's what's really happening from the health, and they were doing it at that time because they were overwhelmed, right? And overwhelmed with people needing a test. Not necessarily overwhelmed with needs for respirators, not necessarily overwhelmed with patient beds, but overwhelmed with people needing a coronavirus test and not having the ability to provide that test.
Dr. Robinson?
Yes.
There are a couple questions. Would you like to take them now, or did you want to wait?
Yes, because I'm actually going to go to that
Great. Just to give you a time check, we have about 19 minutes left.
Okay.
The first question, are the deaths among people of color more so due to SES and needing to work, or more so due to the lack of medical accessibility?
Okay. Again, there's no either or answer to that. This is a complex, multifactorial problem, and I will get into that right now. That's a good segue into the neighborhood, the local corona. So now we looked at it from a county's perspective. Now let's drill down to sub-county and look
Can
at
I ask you, sorry, one other question.
Okay. The first question I'm going to address in the upcoming slide. So I'll just refer that.
Can you please define rate in terms of epidemiology?
Define what?
The rate. I think that you were referring to perhaps from another.
Rates per 100,000 cases per 100,000 persons.
Great.
A rate is how you can compare units against one another. So if you just look at raw cases, it's how many people live there. There's always going to be. So the difference is that the first map I showed was just how many cases there were. So the bigger counties that had more people theoretically might have more cases. Not always the case with the disease. The rate is how many cases per 100,000 persons in that county. So it has a denominator of the people. So it's a rate. That's what a rate is. How many persons per something. So this is the rate per 100,000 persons. So now here's an example of cases. So that's the maps I showed before. This is just a raw case map from Connecticut, right? So now we're drilling down to the racial rates, right? So here is the state of Connecticut with the townships and shaded by the number of cases per township here, right? So if we go back here, and I'm gonna turn off this, and I'm gonna go to the social, the social vulnerability index from the Centers for Disease Control. So those of us who work in health disparities, we are very familiar with the relationship between things like poverty, discrimination, unemployment, and health outcomes, right? Health behaviors and health outcomes, right? So here's the map of Connecticut, and what you see here, darker colors represent areas in Connecticut that have more social vulnerability. This is the entire index. So this combined, so when you ask what is this composed of, so let's just say, look at this area here, I believe this is Stamford, Connecticut. Fairfield County, right? So you look at social vulnerability, an area that's darker is going to have higher social vulnerability. And so what would that mean? going to have more people with no high school diplomas, more people that are speak English as a second language or are African American or Latino, higher rates of poverty, higher rates of unemployment. So there's a whole bunch of indicators that are combined to come up with this index that I'm showing you here. It has crowding in houses. It has a whole bunch of a large variety of social determinants of health, right? 80% minority here, percent minority, 80%. You see that? So when you combine, so the CDC has spent a lot of time taking all those little variables and then putting them into an index. And so when that index is high, it tells you about what's going on in that place, right? So if you look at this map of social, and normally I would have put them together on the map, but I didn't have enough time to get the local data for Connecticut, so I have it in form of a static map here, right? But what you'll see here is that Stamford here, in terms of coronavirus cases, more than 1,000, is also an area of high social vulnerability in downtown Stamford. New Haven, so Connecticut is a state that, although it's wealthier than nearby New York, within a lot of the towns in Connecticut, oh wait, oops, there's a lot of poverty. So that poverty that, is, oh, I gotta plug my thing in, sorry about that. So that poverty is showing itself in terms of more coronavirus cases. So if you look here, let's zoom in here, where's that? This is water something, Connecticut. New Haven County, so it's near the city of New Haven, right? And so again, if we go back here to the presentation, this is New Haven, Connecticut, right? So you ask about the correlation. I have 8 minutes left, so all right. So you asked. Let me go forward to LA County because I don't want to get lost in other states. But if you look at Michigan again, if you look at the social vulnerability index in Michigan, here's Detroit, here's Flint, and you'll see that the pattern is also similar in Michigan, right? So if I go over to Michigan, you're going to find out that the same kind of pattern is clear, where Detroit, Flint have higher social vulnerability on their index, and they have more coronavirus cases, right? Now, I want you to just look at that for a minute, and I have to go get my cord, or my laptop's going to go dead in about a minute or so. So just a second.
And while we're waiting for Dr. Robinson, I just want to draw everyone's attention to the link. It's in the chat box to the GIS website. So it's gis.cdru.edu. Thank you, Caroline, for posting that in the chat box.
And on that note, actually, there's going to be a new site that we've been developing with the UHI and the Health Services Cluster, which will have these maps on it, but it's going to be a UHI Coronavirus Resource Center, and it's going to have a lot of other resources, and it's going to be a place where people that in the Drew community that want to share information about resources and assets or things will be able to post. And we're also going to be able to post interactive surveys where we can gather some of the information that's missing through our own vehicles. So anyway, that will be probably revealed on Friday, tomorrow. But it's up now, but and a lot of the maps from the GIS webpage will be on that too. But again, I don't want to bring up that right now. So let's go to LA County real quick. So now, something weird is going on in LA County, something very strange, because unlike the rest of the country, I can't say the rest of the country, but most of the places that we've looked at, coronavirus does not follow the social vulnerability index in LA County. So I'm going to go back here for a minute and talk about that. And why is that, right? Well, these are some of the potential reasons, right? But I want to get to the map here of all right, so here we go. Let me go down here. So here comes a map that shows yesterday's LADPH coronavirus rates per 100,000 by neighborhoods in LA County. Okay, so this is the map, and we've been updating this map every day, getting the data from the county. This is the rate per 100,000, right? So what you see here is that it's the wealthier parts of LA County that have the higher rates of confirmed coronavirus cases, right? And then when you get down to Willowbrook and Watts, it's lower. This trend was even more severe a couple weeks ago when the tests were even less common, right? And we all know the stories of Will Smith, or not Will Smith, but Tom Hanks and Idris Elba and NBA players knowing that their coronavirus their COVID-19 status very early, right? And it appears that what drove coronavirus testing in LA County early was having money. Now, again, we don't know this, right? We don't know. Maybe it's living in West LA, West Hollywood, and hanging out at bars caused a lot of people to get it. But as we get more testing, we're still not necessarily seeing a reversal in that trend. So look, here's the social vulnerability index for LA County, right? Let me zoom in so you can see that this is South LA, right? Here's Drew, right around here. The poor neighborhood, here's downtown LA, right? Skid Row, South LA, Watts, Compton. This is USC campus, just to get you an idea. This is USC, so everything south of USC, East LA over here, then there's parts of certain areas out in the San Gabriel's, or say over in the San Fernando, like Sylmar, Pacoima. So these are the areas where poor people live in LA County, right? But when you look at the CV19 trends in LA County, it's the opposite. This is the poor people area. This is Pacoima. The most depressed area in the county has a CV19 rate of 70.15 per 100,000, but West Hollywood has a CV19 confirmed rate of 276. Money versus no money. So right now in LA County, we're breaking what I see as a national trend, the normal health disparities trend of poor areas that have high social vulnerability have more cases and more deaths than other areas, right? That the consequences of a virus like COVID-19 come from poverty, right? The exacerbations, right? The questions that were asked about the healthcare set. So that's not what we're seeing yet in LA County. We have a research group, we're actually meeting a little bit later today where we're trying to get to the bottom of this. And my suspicion is that really, and this is where we're going to test, I don't know, but just it doesn't make sense. And what I think is going to happen is that when it's all said and done, that those people that the doctors are sending home without a test, that if they're not being admitted or they're not a healthcare worker, are showing up as pneumonia hospitalizations, or they're not getting hospitalized as pneumonia deaths or bronchitis deaths, but they just are not entering in to the entire picture of the COVID-19 databases that exist in this country. Or else something about being poor and working class in LA County is protective against the coronavirus. So we don't have the answer, but it's got to be something along lines like that, right? So that's it for my presentation about this. And again, these are open questions, right? So to summarize it, while COVID-19 has no race, class, or ethnicity, it knows no race, the history of the US has evolved mainly along those lines, right? And so when you look in most parts of the country, you see those fault lines where things have been segregated by race, where healthcare system hasn't provided equally. You see coronavirus in those areas, right? Health disparities are rooted in social relations, and that they've been exacerbated by COVID-19, right? So the impact in Detroit on that bus, I don't know if you ever saw like the bus driver, there's a great social media, not great, it's very sad and tragic. This bus driver in Detroit was complaining on Facebook Live about this lady who was hacking on his bus, saying that this is real, people. You know, this coronavirus, you can't be doing that. The dude was dead 2 weeks later of coronavirus, right? So when you ask a question about Black people being exposed, we're more likely to be non-clinical. I'm not more likely, but a lot of Black people work in hospitals, not the doctors and nurses, but cleaning up and doing the orderly and something like that. A lot of those people had no PPE. My sister works in a hospital. She's told me that a lot of the people cleaning up were walking in the rooms with nothing on. A lot of them got coronavirus. Bus drivers, transit drivers, being dependent on public transport to get around put you at greater risk for COVID-19, right? And then you're at greater risk to being exposed. Then when you get it, the healthcare system and the differential ways that Black people or minority people are treated can lead to additional negative effects of being exposed to coronavirus. Not access to a respirator. And if you look on our GIS webpage, for example, and look at the number of ICU beds in South LA versus other places, it's ridiculous. Good thing we didn't need all those respirators in South LA, because if you did, and who knows if, again, we don't even know if they're going to be needed in the future, if they should have been needed but never used. This is some real stuff, right? So health disparities, and I'm not saying anything that Dr. Anthony Fauci and all are saying as well, but we've been at the you know, down in the pits of this health disparities thing at Drew, many of us researchers for decades, and still just lip service is being paid to this, right? And let's hope that coronavirus just doesn't lead to more lip service and more ignoring the problem. Because again, these problems are tied to things bigger than health. They're tied to schools, they're tied to jobs, and in some ways, this CV-19 has exposed all of that and may be forcing us to change, to stop some of the practices and things that have grown up over, you know, whoever knows how long in both the country and the world. So having said that, I'm done with this presentation. And again, all this is preliminary, but look for some papers and stuff from the UHI that more directly address this in the near future.
Thank you, Dr. Robinson, for your wonderful presentation. We do have additional questions. I don't know if we'll have a chance to get through all of them, but I would like to share with you. Here's the next question. In your opinion, how long do you think the social distancing approach should continue based on data? How effective do you think it will be as this outbreak continues?
I can only parrot what the experts, what they're saying, in that the social distancing approach is a definite requirement without testing. Now, think of AIDS, right? You can get an AIDS test at the dollar store right now. AIDS testing is ubiquitous, right? But there was a time where AIDS testing wasn't available, and it was this big thing. And so HIV testing is a sort of example of how when there's more testing and people can know their own status, you don't need the social distancing as much, right? So this is all based on, I don't even understand the lab and the system of health doctors being dependent on these labs. I don't even know. I mean, this is something that's got to come out though, right? It's got to come out. So until we get to answer the question and finish this, until you have ubiquitous testing, you're going to need social distancing because it's going to come back. As soon as people open up, people are going to get it again. And that's what they're saying.
And sorry, let me just throw an additional question in, and I'm skipping through. Are you aware of any developing studies about COVID-19 prevalence among homeless population in LA? This population could be visible in both poor and wealthy areas.
I am not aware of any studies on that other than people saying that it could be a big problem amongst the homeless population, but I don't know anything about what's happening with respect to that. I think it's definitely a potential issue that needs to be addressed though.
Great, great. And let's see, we are at time. It's 1 o'clock. Dr. Robinson, I'll share the additional questions with you. I want to thank you so much for taking time and for all you're doing in terms of really being on the ground, tracking these cases and mortality rates, and also everything that you have done, to provide more information and on health disparities and health equity. Thank you all for joining today, and we will keep you posted for our next Haynes series next month. Be safe, everyone.
And you can
Thank
email
you.
me if you have any questions. Anyone can email me if they have any questions about the data or anything like that.
The presentation is going to be available?
Yes. Thank you.